Hello and welcome to this virtual lecture. My name is Dr. Matthew Kolek. I'm a cardiac electrophysiologist or a heart rhythm specialist with Florida Electrophysiology Associates, the largest electrophysiology group in all of Florida. Today we're going to talk about atrial fibrillation and understanding atrial fibrillation. So our learning objectives, number one, are going to be what is atrial fibrillation, or AFib as we commonly call it, and why is it important? Number two, what causes AFib? Number three, how do we treat the symptoms of AFib? And number four, how can we prevent stroke in AFib? So let's start with the first one. What is atrial fibrillation and why is it important? As you might remember, the heart has four chambers. The two upper chambers, which are the filling chambers, are called the atria. The bottom chambers, which are the big muscular pumping chambers, are the ventricles. The way that your heart is activated normally is with a specialized set of cells up in the right atrium called the sinus node. The sinus node depolarizes or fires spontaneously 60 to 140 beats per minute and causes the atria to first contract. The atria fill the ventricles, and that electrical signal is carried down specialized conduction tissue to the ventricles, and then the ventricles contract and pump blood to the body. In atrial fibrillation, however, you have a lot of chaotic, abnormal, and very rapid electrical activity, particularly in the left atrium, and that's the electrical basis for AFib. AFib is very common. You can see from this graph that now in 2021, approximately 8 million Americans have atrial fibrillation, and it becomes more and more common as we get older. In fact, for those of us listening to this lecture who are 40 years of age or older, we now have about a 1 in 4 lifetime risk of developing AFib. So AFib is the most common arrhythmia or sustained heart rhythm disorder in the world. It's a fast heart rhythm that comes from the atria, the top filling chambers of the heart, and it can cause a variety of symptoms. The most common symptoms of atrial fibrillation are things like shortness of breath with exertion, fatigue, palpitations, which is a sensation that the heart is racing or skipping or flip-flopping, dizziness or lightheadedness, chest discomfort, and sometimes even fainting. So why is atrial fibrillation so important? Well, it can cause a very rapid heart rate that can eventually actually lead to heart failure if it is left uncorrected. It can cause the ventricles, the big bottom muscular pumping chambers, to actually wear out and fail. It's important because it can lead to these many symptoms that we've been talking about, and it's also a very important risk factor for stroke, and more on that later. In fact, people with atrial fibrillation have an increased risk for stroke and for death, as you can see from these multiple studies where they've followed patients for many, many years and found that those who develop AFib have a higher risk for stroke and for dying before their time. So atrial fibrillation is very frequently thought of as a heart rhythm problem that's, quote, not going to kill me, end quote. But in fact, it's important to know that it is associated with a decreased survival and with stroke. So how do we diagnose atrial fibrillation? Well, one way we diagnose it is with the EKG, or electrocardiogram. That's a test that is done in your doctor's office, which provides us with a snapshot of what the heart is doing right there and then. And sometimes, if somebody's having symptoms, they come to the doctor's office or the emergency department. We do an EKG and we see right there that they're in AFib. Oftentimes, however, people have symptoms, but then by the time they get to their doctor's office, maybe they're not having those symptoms anymore. And so what we do in that circumstance is we prescribe a wearable monitor. That's a heart rhythm monitor that can be worn anywhere from 24 hours to up to about 30 days, that can pick up these AFib episodes, and is the most common way that we diagnose AFib. The ultimate is these implantable heart monitors, which are very, very tiny and go just under the skin. So for people that are having very infrequent symptoms, that's a good option. Or if we're monitoring how people respond to medical therapy or to ablation therapy for AFib, we will often use these monitors. So, what causes atrial fibrillation? Well, that, my friends, is a very complicated question. As you can see from this slide, there are many risk factors that contribute to somebody's risk of developing AFib, such as increased age, ischemic heart disease, high blood pressure, diabetes, alcohol and drugs. And then there are genetic and familial risk factors as well. So I think it's useful to think of these risk factors in terms of what is modifiable, meaning what can we do as patients with AFib to reduce our risk of having episodes or even reduce the risk of developing AFib, and what are non-modifiable risk factors. So non-modifiable risk factors are things like age, genetics, diabetes, coronary artery disease, heart failure, and what we refer to as left atrial remodeling. We'll talk more about that later. Modifiable risk factors are obstructive sleep apnea. That's one of the most important ones. So it's very important for people to be screened and treated for sleep apnea, those of us that are at risk. High blood pressure, alcohol intake, and obesity. Those are modifiable risk factors that we can do something about. Atrial fibrillation is a progression that happens over time. So it's useful to think of it as something that occurs in the aging heart, where people have risk factors for AFib and perhaps the genetic predisposition to develop AFib. At first, they might develop rare episodes that stop on their own. We call that paroxysmal AFib. Paroxysm is just a fancy medical term for episode. So these are people that have episodes AFib, but most of the time they're in normal sinus rhythm. Over time, and as changes occur in the left atrium in terms of the shape of the atrium, the size, changes occur in the types of cells that are in the left atrium, these episodes become more and more common, and then they actually come to the attention of medical workers. They might require interventions such as medications or procedures like a cardioversion, which resets the heart. And this becomes kind of a downward spiral, if you will, where the more AFib episodes you have, the more susceptible you are to having more AFib. And ultimately, people get what's called persistent atrial fibrillation, which is defined basically as atrial fibrillation that has been going on straight for more than 7 days. This is marked then by even more changes in the left atrium, scarring in the left atrium, and eventually people essentially get stuck in AFib, where they are in atrial fibrillation for months to years, and we call that long-standing persistent atrial fibrillation. Well, why is that all important? One of the very important reasons is because the earlier we intervene in this process, the better our treatments work. So for people that have been having AFib episodes for years and years, or people that have been stuck in AFib for months or years, the success rate of getting them back into sinus rhythm and keeping them in sinus rhythm, both with medications and with procedures such as ablation, is much lower than for people that are early on in that disease state. So, how do we treat patients with atrial fibrillation? How do we treat the symptoms of AFib? With atrial fibrillation, there's a wide spectrum of the types of symptoms people have, as well as the severity of those symptoms. Some people, a small minority of people, actually have no symptoms. They cannot tell when they are in AFib or they're not in AFib. They feel fine, they're able to exercise, they're able to do their activities of daily living. And for those folks, we treat them a little bit differently than the majority of patients which do have symptoms of AFib. Some people have very mild symptoms. Other people have severe symptoms to the point where they go into AFib and they are in the emergency department. Most patients have some symptoms, and we've already kind of discussed what those are: dizziness, palpitations, shortness of breath with exertion, fatigue. And for those people, we try very hard to keep them out of AFib. There are several ways that we can do that. One thing that many of us have heard about is a procedure called a cardioversion. So what is a cardioversion? Basically, it's where we bring somebody to the hospital, and under deep sedation, we shock the heart and reset the electrical activity. It's very quick and very safe, but it's not permanent. It's a very temporary treatment for AFib, and some people go back into AFib within hours or days. So I like to think of a cardioversion similar to if one were to reboot a computer that is having problems with the hard drive. It might get your computer working for the rest of the day, but it doesn't fix the underlying problem or change the history of the disease. We have antiarrhythmic drugs, which are specially designed drugs that work on the electrical currents in your heart, and those are frequently used as a first therapy to treat the symptoms of AFib. Those include medications such as Multac, propafenone, amiodarone, flecainide, sotalol, and Ticasin. Those are our most common antiarrhythmic drugs. And catheter ablation. So that is a minimally invasive procedure that is done for people that either fail medical therapy or they have certain characteristics that makes early catheter ablation a better option, and it's a minimally invasive procedure that's meant to restore sinus rhythm and keep people in sinus rhythm. So what are the pros and cons of each of these options? Well, for cardioversion, it's quick, easy, and safe. It's a very short amount of time in the hospital, and it's a very safe procedure. But as we already discussed, the cons is that it's temporary and it doesn't stop the progression of the disease. Antiarrhythmic drugs, the pros, they're easy. It's just taking a pill every day or a couple of times a day. So for many of us, that's okay. We don't mind doing that. And they do reduce the burden of atrial fibrillation. But the cons is that often people have breakthrough episodes, or often the drugs fail altogether and people go back to having AFib just like they did before. In fact, the efficacy of maintaining sinus rhythm at 1 to 2 years is only about 30 to 40%, so very poor. In addition to that, some people have side effects or even long-term organ toxicities from the antiarrhythmic drugs. So what about ablation? Ablation is our most effective treatment for AFib. For people that have an ablation early on in their disease course, the success rate of maintaining sinus rhythm at 1 to 2 years is as high as 85%. In many folks, we're able to stop their blood thinners after a successful ablation once we've demonstrated that they're maintaining sinus rhythm. So what are the cons? It's a procedure. So there's a little bit of risk involved, as with any heart procedure. It requires an overnight stay in the hospital and all the other things that we associate with having a procedure: anxiety, time off of work, things like that. A little more about atrial fibrillation ablation. So basically, it's done with catheters that we put into the heart through the veins in the legs. And we use the catheters to create some lines of scar tissue on the inside of the atria, the top filling chambers of the heart. And we do that in order to block the electrical signals that are causing the AFib. Scar tissue acts as an electrical insulator, so when those electrical impulses run into the scar tissue, it acts like a wall and those signals are stopped. There are two ways in which we do ablation, and I get asked this question, so I'll go over it here. One way is with what's called radiofrequency catheter ablation. That is a catheter that delivers radiofrequency energy to heat up and cauterize and scar the tissue. And the other common way is what we call cryoablation. That is done with a balloon that turns extremely cold and freezes the tissue and causes scarring that way. For all intents and purposes, these two methods are equal. The effectiveness and the safety is almost exactly the same. So if you're going to have an atrial fibrillation ablation, basically whatever method your doctor is most familiar with and most comfortable with is the right method. So let's go over a couple of examples of patients that might have an atrial fibrillation ablation. These are real patients, but we're not using any patient information. Mrs. C was a 73-year-old lady with a medical history of high blood pressure and recently diagnosed AFib. She had had 2 recent emergency room visits for severe palpitations, and she wished to avoid taking long-term medications, so she came to see me. We did an atrial fibrillation ablation on her. These are maps of her left atrium, so these are 3-dimensional maps that we make of the heart during the procedure. And basically, the purple denotes normal, healthy tissue, and the red is tissue that has either been ablated and is electrically inert, or areas of scar tissue. So she had a very normal-looking left atrium with lots of healthy tissue, and one would expect that she has about an 85% chance of maintaining sinus rhythm in the long term after an ablation. Mr. L, on the other hand, was a 66-year-old male with a history of high blood pressure, obesity, heart failure, sleep apnea, and he had now been persistently in atrial fibrillation for 3 years. He had had 3 previous cardioversions and 1 failed antiarrhythmic drug, and he felt tired all the time and short of breath with exertion. He read about AFib ablation on the internet, so he came to see me. So for him, when we did his procedure, his left atrium looked considerably different. It was a lot larger, kind of more of a sphere shape rather than a football shape like the last one I showed you. And you can see there's all these islands of scar tissue seen here as the red and the rainbow colored areas. And on this gentleman, we did a much more extensive ablation. And even with that, I would expect that his long-term success at maintaining sinus rhythm is probably around 65%, so considerably lower. Again, highlighting the importance of treating this disease early. So, how can we prevent strokes in AFib? Well, during atrial fibrillation, the atria are contracting very rapidly and not moving blood efficiently. So what can happen is blood pools up, it coagulates, and it can form a blood clot, particularly in an area called the left atrial appendage, which is a cul-de-sac, a blind sac that comes off of our left atrium. We determine what somebody's individual risk of stroke is based on various risk factors, and we use that score, what's called the CHADS-VASc score, to help make decisions about who might benefit from a stronger blood thinner or who might be okay taking aspirin. So for example, for somebody who's 66 years old and has a history of high blood pressure but no other risk factors, their CHADS-VASc score would be 2, which correlates to about a 2% chance of having a stroke per year, so pretty low. On the other hand, a 76-year-old patient who's diabetic, high blood pressure, female, that person's CHADS-VASc score is 5, which then correlates with an annual risk of stroke of 7%. So that's pretty high, especially if you think of it over the term of 10 years, then we're talking about 70%. So that person we would definitely want to have on a blood thinner. Aspirin doesn't really provide a whole lot of protection, so it's only used for the very lowest risk patients that don't have any other risk factors. Warfarin is very effective. It was the standard of care for many, many years, but it can be difficult to take for many patients. It requires frequent blood testing and dose adjustments, and often interferes with other medications and even has certain foods that people can't eat because it can affect their warfarin. The new anticoagulants, the most common of which are Eliquis and Xarelto, have really been revolutionary in terms of helping with this problem. They are much easier to take. They're very, very effective. In many cases, they are more effective than warfarin at preventing stroke with lower bleeding risk. The big downside, of course, is they are quite expensive because they're all newer medications. And then there's a procedure that we do called the Watchman device. The Watchman device is a minimally invasive procedure that's done to essentially take the place of taking long-term blood thinners for people with AFib that also have some kind of reason why they can't be on long-term blood thinners. So for example, somebody that has AFib and they have had frequent falls. So we're afraid to have them on a blood thinner because we don't want them to fall and hit their head and bleed internally. Or somebody with AFib who has had problems bleeding in the stomach, like a bleeding ulcer. We don't want that person to be on a long-term blood thinner because we're afraid that they will re-bleed. So those patients are often referred to me to consider a Watchman device. It's a minimally invasive device that's inserted, again, through the vein in the leg, up into the heart, and it basically plugs this left atrial appendage, this area where the blood clots like to form. It's a very safe, quick procedure, and about 6 weeks afterwards, we're able to stop most people's blood thinners for good. So it's been a wonderful option to help those people that would otherwise not be able to tolerate a blood thinner. So we've covered what is atrial fibrillation and why is it important, what causes AFib, how do we treat the symptoms of AFib, and how can we prevent strokes in AFib. And I thank you very much for your time and attention today, and I look forward to meeting you in person.